let me say a few words, and I'm going to give the mic over to you. Whoop, let me get that off the screen. Okay, everybody, we're back. It's right at 2 o'clock. We've got Dr. Johnston from Freeman, another resident. Am I correct, Dr. Johnson? Resident, okay. Aren't you? Resident at Freeman? Trying to introduce you. You're resident at Freeman West, aren't you?
Yes, sir.
Excellent. Make sure I had it right. Didn't want to give you the wrong name or title.
Yep, I'm a third-year resident at Freeman.
Very good. All right, sir.
Alrighty.
All yours.
Thank you. I appreciate it. My presentation will be over head trauma. Like I said, I'm a third-year resident at Freeman, and today we'll go over head injuries, what types of injuries there are, what to look for, the appropriate management, and just kind of a overall summary of everything. So first off, head and brain trauma. There's about 1 million cases annually. 230 are hospitalized and survive. About a third of all injuries are related deaths. Severity, most of them are mild, about 75%, but 10% can be severe with 35% mortality of those 10%. And then concurrently, 5% can have a C-spine fracture as well. 80 to 90,000 significant long-term disability. So the highest risk group for these injuries will be males 15 to 24 years of age, young children, or very elderly. Up to 44 years of age, the leading cause of death is some kind of trauma or accident. So head injury is just kind of a broad, inclusive term. It's a traumatic insult to the head, may injure the soft tissue, bony structures, or brain. You can have specific blunt trauma, or you can have a penetrating type trauma. Penetrating is usually associated with poor outcomes, and it's capable of producing a physical, intellectual, emotional, social, or vocational change. So for the categories of brain injury, you have focal, subarachnoid, or diffuse axonal injury. So focal, that's going to be like your epidural hematoma, subdural hematoma, but we'll get into all the different types as we go along. For mechanisms, most often you're going to have a motor vehicle collision. That's the most common. Sports injuries with younger people, falls with older people, and then penetrating trauma such as gunshots or stabbings or something like that. So for types of injury, you have what's called a coup or a counter coup injury. The coup is the direct impact of the first injury. It's more common when the front of the head is struck. So I'll show a graphic here in a second, kind of illustrating that. The counter coup is the secondary injury that happens as the brain moves around in the skull. And here's that picture that I see pop up all the time. So the impact strikes on the left side of the head there, causes a coup injury, the brain moves around and causes a counter coup or secondary injury. Diffuse axonal injury, so that's a shearing, tearing, or stretching of the nerve fibers. This is on a microscopic scale. There's no gross anatomic deformity. It occurs over a widespread area, and I'll go over that a little bit more. And then the focal injury, it's limited and identifiable site of injury, so that's just your stabbing or shooting, or maybe an epidural, something like that. So the direct primary causes is the impact. That's that coup that I was just talking about, mechanical disruption of cells, vascular permeability of disruption, and then the indirect causes. These are actually something that's what you want to avoid when you're taking care of a head injury patient. If it's a secondary injury, that's going to be hypoxia, hypotension, things like that, and then tertiary injuries are sequelae due to all these secondary injuries. So secondary and tertiary are what you want to avoid. Direct is what you're going to be dealing with, so there's no avoidance of that. It's just supportive to make sure there's no secondary injuries. So in terms of anatomy, the brain occupies 80% of the intracranial space. There's some room to slosh around in there with the CSF, but that's related to the coup, counter-coup. So the divisions of the brain, you have the cerebrum, the cerebellum, and the brainstem, and I'll show a couple of illustrations of that coming up. You have CSF, which is a clear, colorless liquid. It circulates throughout the brain and spinal cord. It cushions and protects, and it's made by the ventricles. Then for the blood supply, you have, excuse me, you have vertebral arteries and your carotid arteries, and they supply different areas of the brain, which I'll show you coming up. This is basically what I was talking about here. On the left side, you can see kind of the venous system here. With the subarachnoid space, that's how you get a subdural hematoma. And then on the right side, you have the arterial system, which shows both the vertebral and the posterior aspect, and the carotids and the anterior aspect. And anytime you get a anytime you get an injury to the middle meningeal artery, that's when you have a epidural hematoma. So the meninges, you have three different layers here: the dura mater, the arachnoid mater, and the pia mater. The duroid is the tough outer layer, and that separates the cerebellum from the cerebral structures. The arachnoid is a web-like venous vessels. And then the pia mater is directly attached to the brain tissue itself. And here's another illustration. It goes through that. So you have your skin, you have your skull bone, and then you have the different layers going down to the brain. Here's one of the best illustrations I could see of that, of real life. And then getting into the outer layers here, the scalp, a scalp laceration or revulsion, it's one of the most common injuries in head injuries. You can have very diffuse bleeding because the scalp is very vascular. It'll bleed like stink. It can have involvement of the galea, which I'll talk about here in a second, and it can produce hypovolemia.
All right, good to go.
Okay, let me. So, like I was saying, the skin or the scalp layer we're talking a little bit about, and how it can involve the galea or not. Then you have the skull itself. Then you have the three layers going down to the brain: the arachnoid, the dura layer, and the pia mater. Excuse me. And here's a good image that I think illustrates possibly all of those right there. And talking about the scalp lacerations, so the galea, it's the aponeurosis. If it's greater than 0.5 centimeters, that needs repair using sutures. If it's not repaired, then it can cause infection or even cosmetic disability. So a lot of times the galea will look like a skull fracture, and it's very difficult to tell unless you can irrigate it out and take a look and get down to that layer itself. But bottom line is that if it looks like either the galea or the skull, it needs to be probably repaired or looked at further. So here's a good way to remember the different layers of the scalp anatomy. You have the skin, connective tissue, the aponeurosis or the galea, loose areolar tissue, and the pericranium. And as I was discussing, the scalp is very vascular. If you have kids or adults that take prolonged extrication, you might worry about it, but more so with the kids, like I was saying, because they can get hypotensive when it comes to head injuries. And then here's one more illustration just showing the different layers. going from the skin in the green all the way down to the dura mater in the yellow. And then that purple kind of layer is the galea, is the thing you got to worry about sometimes. Here is the here's a CT of a skull fracture, and the arrows there are just pointing to the obvious injuries there. The circle shows free air in the skull, or in the head, which indicates some kind of pathology. Skull fracture is present in 60% of patients with severe head injury. You have linear or depressed skull fractures. Linear skull fractures are usually incidental findings. They tend to go away, and at least the pain tends to go away in 5 to 10 days. You usually don't do anything with them. You can admit them for observation, but that's non-surgical. If they have a depressed skull fracture, if it's greater than 5 millimeters, that will need to be surgically repaired, and the mechanism is usually intense with that, with a blow to the scalp with a small surface area object. Types of skull fractures, so you can have basilar, you can have a blow to the temple, most often parietal and the occipital areas. Signs of skull fractures, which I'll show you here with some more illustrations. You can have hemotympanum with bloody ear discharge, rhinorrhea or otorrhea, battle sign, raccoon eyes, or cranial nerve palsies. And here's the illustrations I was mentioning. So for battle sign there, you can see it on the left picture. That's pretty obvious, but a lot of times when somebody will have a skull injury, it may be more subtle. It can be occluded by the ear, and you need to take a better look at it when you're looking for signs of injury. The right top picture is kind of a creepy image, but it's raccoon eyes. That's a sign of skull injury. I had a lady come in that looked almost identical to that. And then lastly, on the lower right hand is ear discharge. It's difficult sometimes with that as well, because you can have bleeding that drips down into the ear versus hemotympanum versus ear discharge. So just kind of use your best clinical judgment there. There's signs of skull fractures again, just kind of summarizing what I said. And then closed head injuries, you can have focal versus diffuse. Focal is your epidural hematoma, subdural hematoma, and cerebral hemorrhage, and then diffuse is your concussions and your diffuse axonal injury. This illustrates a epidural hematoma, so a blow to the side of the head, temporal bone. Usually in younger people, a lot of times football players will have this, or athletes of some kind. Then this is an arterial injury, so it's blood between the skull and the dura. It's an arterial tear. The middle meningeal artery is the most common, and it can cause intracranial pressure. This is a episode of unconsciousness followed by a lucid interval. So when they get hit initially, they'll go unconscious, they'll wake back up, and then as that brain starts to fill up, the intracranial pressure starts to increase, they'll go unresponsive again. And you can get decreased loss of consciousness, headache, nausea, vomiting, hemiplegia, paresis, unequal pupils. Usually you get a dilated pupil on the side of the bleed, and then if they start developing increased blood pressure, decreased pulse, and regular breathing, that's your Cushing's reflex, and that's signs of herniation. This image is illustrating a subdural hematoma. There's a bleed on the CT image of the left frontotemporal. You see mass effect there with a midline shift, so you see the ventricles shifting over to that right side caused by the bleed, so that needs to be taken care of surgically. And this is a low pressure system, or the venous system. It's between dura mater and arachnoid layer. It's more common. It's usually caused by tearing of the bridging veins between the cortex and the dura, and it also causes increased intracranial pressure. It's a slower, more insidious onset. You can get headache, decreased loss of consciousness, and unequal pupils. You can also get the Cushing's reflex with this. So the subdural has a higher mortality than the epidural, but the patient population for this is older people. It's alcoholics. versus the young, healthy people that we mentioned with the epidural. So it may just be the patient population versus the actual injury itself. This is a intracranial or parenchymal hemorrhage. It's due to a laceration of the brain and then bleeding in cerebral substance. It's usually associated with other injuries. You can have the neurodeficits depend on the region involved, and then, of course, you get the intracranial pressure increase as well. Concussion. So this is transient loss of consciousness. You can get retrograding amnesia and confusion. Resolve spontaneously without deficit. It usually only lasts a short time, so you need to ask about any kind of symptoms of concussion for any patient that's sustained head injury. If they seem like they have a concussion, it's best to just make sure that they don't have a more serious injury that's proven by a CAT scan, because they could have, like I mentioned, the epidural hematoma. It seems like it's just a concussion, but then they lose consciousness again. So just make sure that they're not having any more serious injuries. This image shows the diffuse axonal injury, like I was mentioning earlier. So this is a tearing and shearing at the microscopic level. This is not a macroscopic injury. It's caused by rapid acceleration, deceleration injury, like a motor vehicle accident. No gross anatomic abnormality, and it says it's the most common CT finding after severe head trauma. So prolonged post-traumatic coma due to mass lesion or ischemic insult. If somebody slips into a coma, it'd begin at the time of trauma. A severe diffuse axonal injury is one of the leading causes of death in traumatic brain injury. This is an example of penetrating trauma. As you can see, a bullet has gone through from the left side to the right side here, and you can see the bullet fragments. The severity of a penetrating head trauma obviously depends on the energy of a missile. It could be a shotgun versus a .45. Depends on the path and the amount of the scatter of bone and metal fragments. This can be accompanied by severe face and neck injuries, blood loss, difficult airway, and spinal instability. So what happens when you get these kind of head injuries? How does that intracranial pressure increase? So they'll become hypotensive, which results in a drop in cerebral perfusion pressure, which causes cerebral vasodilation, which results in an increase in blood volume and an increase of intracranial pressure and a decrease in cerebral perfusion pressure. So you're trying to compensate for that. And the more that happens, the more the cycle starts over and gets worse and worse and worse. When herniation occurs, there's a couple of different types of herniation: cingulate, transtentorial, and uncal. Uncal tends to be the worst. That's where you have a blown pupil, contralateral paralysis, and that's when respiratory complications occur. This is the Cushing reflex. If you see somebody that's got irregular respirations, they've got high blood pressure and bradycardia, this is the one you got to worry about. But cingulate and transtentorial are also can be very debilitating as well. So when you're assessing any kind of head injury patient, your level of consciousness, that's your best indicator. If they're altered, there could be intracranial trauma. And if they're unable to follow commands at all, there's a good chance that that will need some kind of surgery or some treatment. You can assess by doing the APU scale: alert, response to verbal, response to painful, or completely unresponsive. You can do the GCS, eye, verbal, motor. Eyes, I remember as EYES is 4, voice, VOICE is 5, arm, leg, that's 6. And this is good because it's a reliable measure and you can repeat it. And there's all the different components to the GCS. So for eyes, if they have unequal pupil plus decreased level of consciousness, it could be compression of the oculomotor nerve, possible mass lesion, and the uncal herniation, which we discussed. So that's something that needs to be evaluated. If it's unequal pupils plus an alert patient, this could be due to a direct blow to the eye or an ocular motor nerve injury. You'd be less concerned with a patient like this, but I would still be concerned about either one. Verbal, you just want to make sure they're oriented to person, place, and time. Are they confused? Can they answer your questions appropriately? Are there inappropriate words? Are they just word salad spouting off things? Or are they just making sounds? And then lastly, movement. Are they able to move all the extremities? How do they move? Are they decorticate? Are they decerebrate? Hemiparesis or hemiplegia, paraplegia, or quadriplegia? All these things you have to take into account for GCS. And here's an example of decorticate versus decerebrate. Decorticate, it's the cerebral hemispheres, and they tend to have better outcome. It's higher up on the GCS than decerebrate. Lateralized or focal signs. This could just represent a deficit from the head injury itself. Altered motor function, it could be, so if they're unable to move something on the right side, it could be due to a brain injury, or it could be due just they fractured that arm, or they've dislocated it, or something along those lines. And a lot of times it can be difficult to tell in a patient who's altered. Cushing striatum, we talked about that several times now. And then increased blood pressure, decreased pulse, and irregular respiratory pattern. So we've talked about the hypotension in adults versus children. You won't find that in adults as much as you will in children, unless there's possibly a very prolonged extrication where they're just continuing to bleed, but that would take quite a while. Make sure to look for any other life-threatening injuries along with the head injury. As I mentioned at the beginning of the PowerPoint, there's a good chance that they have a concurrent C-spine injury as well, so always take C-spine precautions. Summary for assessment. So your most important sign is the level of consciousness. Direction of change is more important than single observations. You want to continue to reassess. Importance lies in continual reassessment. And then if they have unequal pupils and they're altered level of consciousness, that's something that needs to be addressed very quickly. So goals for treatment, you want to maintain oxygenation, good blood pressure for brain perfusion, and avoid that secondary brain damage like we talked about. If a patient has a single episode of hypotension and head injury, that doubles patient mortality. If they are hypoxemic, it's a strong predictor of a poor outcome. So not necessarily that they become hypoxemic and they do worse, it's just a predictor of them doing worse further down the road. Airway management, like I said, you want to always assume C-spine trauma and use jaw thrust with C-spine control. Suction is needed, and then intubate if no gag reflex. You want to have a lower threshold to intubate these patients as they can decompensate rather quickly. Oxygenate 100% O2, ventilate. If they do have a head injury, you don't want to routinely do hyperventilation. I'll talk about one instance in a minute where they could possibly use hyperventilation, but that's not routinely done. Respiratory patterns you want to look for, the Cheyne-Stokes, that's the diffuse injury to cerebral hemispheres. That's irregular with periods of apnea. Central neurological hyperventilation, that's injury to the midbrain, and then apneutic, that's injury to the pons. It's an abnormal pattern of breathing characterized by deep gasping inspiration with a pause at full inspiration, followed by a brief insufficient release. So they take a really deep breath and then they don't fully exhale afterwards. That's called apnosis. So hyperventilation, if they show signs of cerebral herniation, some of those things I have listed there, posturing, pupillary abnormalities, and of course the breathing abnormalities, then you could think about doing hyperventilation. I've seen a couple studies that kind of are trying to do away with this right now, but decrease in GCS of more than 2 points in patients with initial GCS less than 9, and then they have the recommended breaths per minute there. And if you're using end-tidal CO2, you want 30 as your target for hyperventilation. Benefits, it decreases PaCO2, causes vasoconstriction, decreased intracranial pressure. You also can cause decreased cerebral blood flow and decreased oxygen delivery. So I think that's kind of why they're trying to shift away from this, as it could be potentially more harm than good, and it can cause increased edema as well. Circulation, you want to maintain adequate blood pressure and perfusion. You can give IV fluids, normal saline, lactated ringers, that sort of thing. Titrate up systolic blood pressure of 90, and just monitor your EKG for any changes. IV therapy, drug therapy considerations, really, after maintaining the ABCs, you just want to make sure that they're not seizing, so benzos if they need it, and then RSI if they are having irregular breathing patterns or they're not maintaining their airway well. Glucose, you want to address glucose only if they're hypoglycemic. Hyperglycemia can harm brain injury. Hyperglycemia can harm patients who've had a head injury caused by osmotic shifts. And then if it's your old elderly alcoholic, you consider thiamine as well. When you're transporting a head injured patient, you want to choose trauma center. Freeman is trauma 2, so there's not a lot that we won't take. Any moderate and severe GCS need to go to a trauma center where neurosurgery is available. If they need to go by air, let's say that the closest thing was an hour and a half away, you could consider transporting to air. And then the severe injuries need to be recognized so that they can get their definitive treatment. One of the last things here is helmet removal. If it's a football player, you only should remove it immediately if it's interfering with the other priorities. So if their airway, if they're not maintaining their airway, ventilation, if there's C-spine motion and restriction, or they go into cardiac arrest, obviously you're going to take it off and do what you need to do. May only need to remove the face piece to access the airway, but if you do remove the helmet, make sure that you've had training procedure, requires another person, and you need padding under the shoulders if the shoulder pads are left on. And as in, for summary, make sure you have good spinal precautions, avoid the hypoxia and the hypotension, consider early intubation for these patients as they will decompensate, avoid the hypotension, like I said, frequent reassessment, and if they are herniating or you assume that they're herniating, you can do the hyperventilation. And that is it.
Excellent. Thank you, Dr. Johnson.
Thank you.
We just take a moment here and see if there's any questions. If you got an extra minute or two.
Sure.
Any questions?
Nothing so far.
I have no
Okay.
questions, sir.
Dr. Johnson, we don't apparently have any questions for you right now, so.
All right.
Okay, folks, we're still here. We may take a break for a couple of minutes and put in a different presentation for the next bit. Our next speaker is another physician resident, and he's not scheduled until 3:30, so that's right at an hour. So honestly, we're going to figure out something to do for the next few minutes. So give us a couple. I'm going to go ahead and sign out, and we'll sign back in a few minutes. Give us about 15 or so. Thank you.